Low risk, very low risk, is low risk but only T1C. You have less than 3 cores that are positive, less than or equal to 50% of each core is positive, PSA density of less than 0.15. So the way I remember this is less than 3, 50, and 0.15. That's very low risk, so the patient can jive. Low risk is Gleason 6, PSA of less than 10, T1A to T2A, think 610 area code for Gleason less than 6, or including 6, PSA less than 10, and up to T2A. The management for very low-risk prostate cancer, if a patient has a greater than 20-year life expectancy, you do active surveillance. Current active surveillance schedule is enumerated by 1 and 2 here. It's a PSA every 6 months and DRE every 12 months. You do a multiparametric MRI every 12 months and repeat a biopsy every 12 months. Alternatively, if the patient wants, you can do IMRT or brachytherapy alone. You do radical prostatectomy with pelvic lymph node dissection if the probability of lymph node mets is greater than 2%. The patient has a 10 to 20-year life expectancy, active surveillance is recommended. If they have a less than 10-year life expectancy, observation is recommended, monitoring every 6 months, treating only for symptoms or a PSA greater than 100. You can consider treating with palliative ADT, or for progression, there's no need for biopsy. In contrast, patients with only low-risk disease, which again is Gleason 6 or less, PSA less than 10, T1A to T2A, if they have a greater than 10-year life expectancy, they can pursue active surveillance, which again is PSA every 6 months and DRE every 12 months, with multiparametric MRI every 12 months and repeat biopsy every 12 months. They can get IMRT or brachy alone. They can get radical prostatectomy with pelvic lymph node dissection if the probability of lymph node mets is greater than 2%. This is preferred for patients with a young age. Consider salvage radiation, positive margins, ECE, seminal vesicle invasion, or detectable PSA. Adjuvant ADT and EBRT if lymph nodes are positive. For a less than 10-year life expectancy, observation, again monitoring every 6 months, treating only for symptoms or PSA greater than 100, treat with palliative ADT or treat with progression. Active surveillance evidence paradigm as per Toronto, Klotz, or Hopkins. This is a PSA every 6 months, a DRE every year, and targeted biopsy if Gleason increases, biopsy no more than every year. Triggers to treat, approximately 30% at 3 years and 50% at 15 years. Clinical progression, meaning a PSA or DRE prompting a biopsy. Progression on biopsy, which is either an increase in the Gleason score, an increase in the number or percent of cores positive. 69% overall survival at 15 years, 99% cause-specific survival at 15 years. The PROTECT trial, this is HAMD NEJM 2016. This is 1,643 PSA detected prostate cancer, any Gleason score, age 50 to 69. They were randomized to active surveillance, 55% of which ended up having treatment versus radical prostatectomy. Most surgeries were nerve-sparing versus radiation. 3D conformal RT was 74 gray and 37 fractions with 3 to 6 months of ADT. Adjuvant and salvage radiation were allowed. 10-year outcomes with radiation versus surgery. There is no difference in prostate cancer mortality, distant mets, disease progression, ADT salvage, or all deaths. Active surveillance had worse prostate cancer mortality, distant mets, disease progression, and ADT compared to radical prostatectomy and radiation. However, all-cause mortality was similar. Active surveillance versus radical prostatectomy versus radiation. 10-year prostate cancer mortality was about 2% versus 0.67% versus 0.73%. Distant mets 5.6% versus 2.4% versus 2.7%. Disease progression 20% versus 6% versus 6.6%. ADT salvage 8.7% versus 4.8% versus 5.6%. All deaths 11% versus 10% versus 10%. Results similar in per protocol analysis. And importantly, Gleason grade group sub-analysis. Group 2, prostate cancer mortality less with radiation, 2% radical prostatectomy and 0.8% RT. Group 3 to 5, prostate cancer mortality was 2.3% with radiation. 2.3% with radical prostatectomy versus 2% radiation. Quality of life, 6 months sexual dysfunction, 95% radical prostatectomy versus 88% RT. Later sexual function with radiation matches active surveillance. 6-month radical prostatectomy incontinence, 55%. 12 months was 20%. 6-month RT bowel dysfunction is 5%. Radiation bowel function recovered later except for bloody stools. Urinary voiding and nocturia was worse with radiation at 6 months and then recovered to similar to other groups at 12 months. No difference in secondary malignancies. Bottom line, radiation and radical prostatectomy show no difference in prostate cancer mortality or distant metastasis. Prostate cancer mortality and distant mets were worse in active surveillance. Radiation and surgery have different adverse effect profiles. Surgery has more incontinence and sexual dysfunction. Radiation has more nocturia, urinary voiding issues, and slight risk of bowel dysfunction. Sexual dysfunction with radiation matches active surveillance and later follow-up. Commentary here is most patients fit the low-risk criteria. 78% were randomized, the rest chose their therapy. Modern radiation with IMRT and dose escalation should have even better results to 3D conformal radiation therapy on this study. ADT was added to this trial even though it doesn't have a clear benefit in low risk or favorable intermediate risk disease. Regarding sexual dysfunction, note that all who had radiation also had ADT. Most radical prostatectomies were nerve sparing and intended to preserve sexual function as much as possible. Surgery, prostate and seminal vesicles with periprostatic fat with vesicourethral anastomosis. There are 2 critical incisions at separating the prostate from the distal urethra and the prostate from the anterior and posterior bladder neck. Type is whatever your urologist is best at. In terms of toxicity, follow-up, and outcomes. Outcomes, 80 to 90% biochemical progression-free survival, greater than 95% cause-specific survival, 1/3 to 50% avoid treatment with active surveillance.